just for the third year medical students, all pediatric and med-teach residents do grand rounds as part of their graduation requirements, as part of hourly activity. And today, Dr. Craig Greenman is going to talk about CPT coding, and it's something that I think none of us get enough of. I think even those of us who are coding, they're always changing things, and so I think that this is going to be a great topic for us to learn from.
Thanks, Cooper. Can everybody hear me okay? People in the back? Okay. So I chose this topic for several reasons. One, I felt like, maybe we don't get enough of this, like in residency training, and then we get out, and then, the people in the billing department are telling us, how we should be coding stuff and billing stuff. And I don't know what those people's education is, maybe a high school education sort of thing. So I kind of wanted to be at least as competent at this as they are, since I figured it, all the liabilities on me. I thought it would be something high yield for the residents for that reason. And so I kind of, decided to do my grand rounds on this. For anybody walking around the med school seeing like the bulletin board, EM doesn't stand for emergency medicine. So I saw that walking in this morning. So we'll get into that, but it's nothing to do with the ER. So anyway, this is kind of a big topic. There's 2 whole sets of guidelines written on this back in the late 90s. So this, cleverly titled A Rapid Review of it, since I'll really only have an hour to go through it. So most of it is the basics, and then we get into a little bit of inpatient and outpatient, and then a few examples there to kind of highlight, what I'm talking about. So first of all, the disclosure statement. I don't have any financial connection or interest with the topic. So the main objectives, to kind of familiarize ourselves with the 2 sets of guidelines I was referring to. One was done in 1995 and the other was 1997. They were put together by the CMS and the AMA. CMS is Center for Medicaid and Medicare Services. So they put together a set of evaluation and management guidelines. We also want to identify just a couple key differences between the 2. There are a lot of similarities between 97 and 95, but there's a couple things as it pertains to the basic stuff, things that we do in the clinic and sort of thing, and kind of go over those key differences. Identify the key components of the guidelines and learn the requirements for each as it relates to the inpatient and outpatient encounters, both new encounters and established visits, and then touch a little bit on like admission H&Ps versus like daily hospital progress notes. And then I'm going to briefly go over at the end kind of well child visits and how we code that, and what happens if they have an ear infection at a well child visit and that sort of thing. So I'm just going to start with a quick case, pretty typical thing for us. So the ER physician calls you to admit a 3-year, 2-month-old black female, past medical history of asthma, presented to the ER, had a 3-day history of URI symptoms, and then mom says the kid started wheezing, earlier today. They tried some home breathing treatments, and she maybe got a little bit better, but it really only lasted briefly, so then brought her into the ER. Got worked up in the ER with labs, x-rays, that sort of thing, and then got several treatments, dose of steroids, and then they called to admit the child. So as I go through everything, some of this stuff isn't per se exactly what we would do as far as evidence-based medicine. The reason it's all set up the way that I wrote it is for the coding purposes and for billing purposes. So, if you see a case and you're like, well, we wouldn't do that. It's there for, me to illustrate the point as far as how we would code or build the encounter. So just kind of keep that in mind as we're going through some of this. So how much is this encounter worth? Well, so far it's worth nothing. We haven't documented anything, and staff tells us if you haven't documented it, you didn't do it. So I kind of get tired of hearing that, but that's just kind of the point of our encounter is only as good as our documentation and what we put down in the note and how we address things. So let's get started with kind of the basic things. So E&M stands for Evaluation and Management. The guidelines, I said this already, were created by the AMA and CMS. There's two sets, 1995 and 1997. There's been none done since then. So you can use either set of guidelines. CPT stands for Current Procedural Terminology. There's three key components to the E&M system and its set of guidelines. So CPT codes, the 5-digit codes that we use for like office visits and that sort of thing, that's what I'm referring to there. There's like several different categories of them. There's a whole set of CPT codes for like anesthesia purposes, and then for surgical purposes, and then for primary care purposes, and I forget the other categories, but I obviously didn't go into all of those. But it's a pretty big system with a lot of different categories, and how they relate to each, or several of the different specialties. So the key components, this stuff is pretty basic. So history, physical exam, and then medical decision making, or assessment and plan, as we think about it, like how it highlights in our note. 4 levels exist for each component. I'm going to illustrate all that in a second. The big thing is every encounter, whether it's an inpatient or outpatient encounter, needs to have some kind of title, like a chief complaint, a reason for the encounter, a reason for the visit, even if it's just follow-up, medication refill, whatever. It has to have a reason for the encounter kind of clearly stated at the top. So get into the history. So here's the 4 levels: problem-focused, expanded problem-focused, detailed, and comprehensive. And then here's a table of how each of those, how you meet the criteria for each of those. And the big thing at the bottom is all 3 of them are required. You have to hit that level in all 3 categories to meet this level of history. So a problem focus, everybody can read this, but a brief HPI versus an extensive HPI, and we're going to get into that in just a second. Those are the 2 types of HPI. PFSH, past medical history, family history, and social history. So past medical history is, chronic conditions, surgeries that they've had, medications, allergies. That's all past medical history. Family history is pretty intuitive, and then social history is also pretty self-explanatory. And then review of systems. So this is the number of different systems for each level. So you can see for the problem focus, you don't even need a review of systems. And then 1 review of systems for the expanded problem focused, and then 2 to 9 systems for detailed, and then a full 10 systems for the comprehensive history. And like I said, all 3 are required for each given level of history. So going on to the HPI, the elements of the HPI. So I talked about brief versus extensive, and this kind of explains how we meet the criteria for each of those levels. So the elements, there's 8 different ones, and they're basically, if you think back to med school, our old CARTS questions. So location, severity, quality, context, timing, duration, modifying factors, associated signs and symptoms. So that's the 8 elements for the HPI, and if you come back to here, brief versus extensive. So down below that, brief versus extensive. Brief is 1 to 3 elements, and then extensive requires at least 4 elements from this list. So that's the 95 guidelines. The 97 guidelines say, so this is maybe more pertains to the med-peds people in the adult population. You can comment on the status of at least 3 chronic medical conditions. So if somebody comes in with high blood pressure, diabetes, and high cholesterol, and you mention that in the history, then you automatically meet criteria for an extensive HPI just by saying they have that medical history, according to the 97 guidelines. So this is one of the big differences between the 2, but actually in the last couple of years, it's not so much a difference anymore if you look at this. So since 2013, the guidelines for extensive can be mixed and matched. So this is one exception to the rule of you can't mix and match 95 and 97 guidelines. So past medical, family, and social. I kind of mentioned this already, so I'll just kind of buzz through this, and most of it's pretty self-explanatory. 95 and 97 guidelines here are pretty much the same. One thing to kind of mention is, so if you're doing the social history and you say, okay, well, they deny tobacco, alcohol, drugs, or they live with mom and dad, or this or that, it doesn't have to be an exhaustive social history to meet criteria. If you just say, like a lot of times in our outpatient notes for adults, we'll put, 35-year-old black female non-smoker. And then I've met criteria for my social history because I mentioned whether or not she smokes. So it just has to be one thing. So I just kind of point that out. And then review of systems, they give the options of 14 body systems, and here they are listed here, so we'll go through that. So except for the extensive one, we needed 10 of those to be reviewed. So shortcuts that we can use in doing the history. HPI, there's no shortcuts. It has to be done by the provider, by the physician or mid-level or whoever is doing the encounter. It has to be documented by them during the encounter. The past history and the review of systems, there's a couple quick shortcuts. This can, if you've ever gone to the doctor or taken your child to the doctor sort of thing, or some other family member, they do these things in different doctors' offices. They do it different ways. So this is one thing you may have noticed. It can either be done by the office staff, if the nurse comes in ahead of the physician, or they'll give you like a little questionnaire to fill out while you're in the waiting room. So review of systems may be part of that. Obviously past history. This is one other shortcut. For the review of systems, and this is another big reason I'm glad I did this. We hear a lot of different things throughout residency of things you can and can't do, but then you see people in other services doing some of the things you were told you couldn't do. So this is one of them that sticks out in my mind. For the review of systems, it's acceptable to document the pertinent review of systems as it relates to the chief complaint and the HPI, and then to state all other systems are reviewed and are negative. That's an acceptable shortcut. Now, the caveat here is this isn't acceptable with all Medicaid providers. I think it's Medicaid providers, as it varies from state to state. So, you need to check with your local, provider and see if it's accepted by them. If it's not, then you have to, list it all out. And I don't know what it is in Louisiana here. I'm not sure. I didn't get into it, but I just kind of wanted to mention this is acceptable at some places, and then other places it's not. So
I'm pretty sure we can do that, but what I see most of the time is review of systems CHPI. It doesn't say all other systems reviewed.
No, it has to be this. Yeah, right. And I knew
that is not showing up in notes.
Yeah, and I knew you would. I'd put this in here for you, Dr. Broussard. I knew you'd get excited at this. So yes, sir. Yeah, it has to be. It doesn't have to be. It basically almost has to be verbatim these words. You can't shortcut it any other. The safest way to do it is to put it like this. So document the pertinent ones and then write this. So
You really do review them.
yeah, that's the other big thing. It's fraudulent to not review them. So keep that in mind too. So maybe it's a shortcut in typing the note, but in taking the history, you have to do an exhaustive review of systems. So anyway, there's a star next to that one because I figured that'd be an interesting topic for everybody. Physical exam, this will look pretty similar to the history. Problem-focused, expanded problem-focused, detailed, and comprehensive. So that makes life simple. So physical exam, these are 95 guidelines. Just keep in mind at the top. I'll do 97 in just a second. So the 95 guidelines with physical exam are actually pretty vague. So you can do an exam as it pertains to 7 body areas, and here they are listed here, or 12 organ systems. And then here's the 12 organ systems listed. You can do either or. And then here's the outlined for the 95 exam and the requirements. So once again, our level of exam over here, and then problem-focused, expanded problem-focused, and then detailed with the different number of areas, the requirements for the different body areas. And then notice that the comprehensive, it goes by systems. You have to do at least 8 of 12 systems. So 95 is kind of complicated. I guess it was their first shot at doing this, and they didn't, this was kind of vague. And one other thing that I noticed was this may vary from like place to place. So some of them may say, well, no, for the detailed, we want 6 to 7 body areas documented. So this is kind of vague, and you need to kind of check.
What do they mean by body areas?
Well, it's back.
Hands, feet, arms?
Yes, sir. Yeah. So right here, so head and face is considered one area: neck, chest, abdomen, genitalia and buttock, back, and then each extremity. That's how it's broken up. Like I said, these are kind of vague. So I think, as I think back and look at my documentation or read other people's notes, I would say most of the ones that I've noticed or read kind of more document by organ systems, and probably more so by the 97 guidelines, whether they know it or not, that they're actually doing that. But anyway, I'll get into that next. So this is kind of vague and not terribly helpful as far as the 95 guidelines are concerned. The 97 guidelines go by 14 organ systems for physical exam, and it's kind of the same organ systems as you would expect. And here's the criteria for that. So for problem focus, 1 to 5 bullets; expanded problem focus, 6 to 11 bullets; detailed, 12 bullets. Comprehensive needs to be 2 bullets from each of 9 different systems. Now, what's the bullets that I'm talking about? There is a table in the 97, like if you go to cms.gov and you look up those guidelines for 1997 and you go to the physical exam section, there's a table with a specific list of bullets, and it wasn't being very cooperative as far as putting it in here. It's kind of exhaustive, but I'll just mention a couple of them just so everybody kind of understands what I'm talking about. So under the constitutional section, if you document 3 vital signs, that's a bullet. If you comment on the patient's appearance, that's a bullet. Respiratory system. So you auscultate, that's a bullet. You have to document whether the patient's in distress or not, so their work of breathing, that would be another bullet in that system. The cardiac exam, you auscultate, that's a bullet. You palpate for PMI, that's a second bullet. You check pulses, that's a bullet. So just understand that there's specific set of bullets that you have to hit on. And I mean, we all use Epic. It seems to me, looking at this and then kind of thinking back about how Epic is set up and split up, most of the clicks in Epic are like meet criteria for one of the bullets. It seems like obviously it was created with that in mind, so which makes sense. So, but just notice that, like for example, the big one that I think of is the respiratory system. I'm clicking through the bullets in the physical exam section for respiratory or pulmonary. And I mean, you have to not just click breath sounds normal, no crackles or wheezing. You have to click on the no distress noted to meet the second bullet in that system. So that's just one example. But anyway, so that's what they mean by bullets for the physical exam section in 97. Now, medical decision-making, kind of the most important one. So here's the 4 levels of medical decision-making: straightforward, low complexity, moderate complexity, and high complexity. And this kind of gets further broken down. I'll show you in a second. So makes life easy. 95 and 97 rules are pretty much the same here. There's 3 dimensions of the medical decision-making, and I'm going to have a couple graphs here in a second to illustrate this. It's based on the patient's problems, the data that you get, so labs, x-rays, etc., and then the risk of their condition and treating their condition. So what do I mean by that? We'll get into that in just a second. Now, this was kind of vague too, as they illustrated it, until they broke it down into like a point system to kind of make it easier to figure out. So here's the medical decision-making table. So like I said, level of medical decision-making over here. The number of problems that the patient has. So it was kind of first done as minimal, limited, multiple, or extensive. And then this is basically the number of problems that you have to meet for that level, basically. Same thing with data, minimal, limited, moderate, or extensive, and then this would be the number of different data points that you would need for each. And I'll get into that in just a second, what exactly qualifies as one piece of data versus two, that sort of thing. And then risk, minimal, low, moderate, or high risk, and there's a table for that to kind of better illustrate what we're talking about. So for medical decision making, you only need 2 out of the 3. Only 2 out of the 3 are required to qualify for that level of medical decision making. So you need either the risk in the data or the risk in the problems, or whatever combination you use, but you only need 2 of the 3. You don't need all 3 levels to match up in moderate complexity to meet for a moderate complexity visit. So here's the point system is first. So the problem points, a self-limited or minor problem is worth 1 point. An established problem that's stable. So somebody comes in with hypertension, they're on 1 medication, and their blood pressure is well controlled. It's stable, so that would be 1 point. Something that's established but worsening would be worth 2 points. A new problem but no workup is needed is worth 3 points. A new problem that needs workup is worth 4 points. And then at the end of the encounter, you can add up all your points, and then you come back to the table and see where it fits in at. New versus old is relative to the provider, not the patient. So someone who recently moved here from Oklahoma and has a history of ADHD, well, that's a new problem to you. This is the first time you're seeing them. You don't need a workup for it, but it's a new problem. So that would be like an example where that would be a problem worth 3 points. So this is something kind of important to take note of. Data points. So if you review or order any lab work, it's worth 1 point. It doesn't matter how many labs you get. So a CBC, a chemistry, a CRP, all this stuff, it's still just 1 point. You reviewed it or ordered it, it's 1 point. Now, you don't get a point for each, so you can't order it and then review it a couple hours later and get 2 points that way. It's one or the other. Same thing for x-rays. You can't double dip there either. You get 1 point for x-rays. So ortho comes in here and they want an x-ray from head to toe. That's 1 point. It's not the number of x-rays you get. So other tests. So you get a point for each of these. So you need an echo or PFTs or this or that. Other tests are 1 point. So let's say a patient comes in, an adult patient with chest pain, and you call cardiology and they do a heart cath and yada yada yada. You call the cardiologist to review the results. That would be worth 1 point. You discuss the results of the test or procedure with the provider who performed it. That's worth 1 point. You have to document what your conversation was or what the results were, but that's worth 1 point. If you independently review a study yourself, that's worth 2 points. So if you look at a chest x-ray and you put your interpretation in your assessment, in the bottom of your note, that's 2 points. Same thing for an EKG or whatever the test is. If you do it, review it yourself and interpret it yourself, you have to document what your interpretation was, but you get an extra point for that. If you obtain old records, so the patient who moved from Oklahoma with ADHD and you tell your nurse, well, I want to get a copy of their Vanderbilt forms from their provider in Oklahoma. So that's worth 1 point if you document that you're going to obtain their old records from the outside provider. Review and summarize old records. So this would be kind of similar to above. You have to document, that you reviewed them and basically kind of what the key points were that as it pertains to the visit. So Now this is, I don't know, in my opinion, maybe kind of the most important thing throughout the whole thing because it kind of drives everything. This is the table of the risk table. So the levels of risk were minimal, low, moderate, and high, and then some of this may be harder to see for some people, but this is the three things that our risk were based on. So they're presenting problems, the diagnostic studies that you're going to get, and then the management options. The important thing here is you only need one of these to meet for that level of risk for the medical decision-making table. So for example, up here, minimal risk would be like a self-limited problem. Somebody comes in with a sore throat and it's a viral URI sort of thing, or viral pharyngitis. That's a minimal self-limited problem. There's no studies that are really needed for that, and you're gonna say saltwater gargles and rest and plenty of fluid sort of thing. That's a minimal problem. Something that would be an example, like of a high risk problem. So down here, one or more chronic illnesses or a severe exacerbation of one of these illnesses. So somebody comes in with an asthma exacerbation and needs supplemental oxygen, IV steroids, yada, yada, yada. You meet criteria for a severe exacerbation of that chronic condition. So anyway, so just kind of know where these things are, have an idea of where these are at. Management options, low. This would be like an example of the most common example with this would be you recommend over-the-counter medications. Say, okay, we'll take some Tylenol for whatever. So moderate would be prescription drug management, would be probably one of the most common things over here. High, so anything parenteral control, any parenteral controlled substances, which may be more for the adult population, but so drug therapy requiring intensive monitoring for toxicity. So basically anybody in the hospital getting vancomycin and getting Vanctrolfs, that meets criteria right here for high complexity encounters. So just a couple things to keep in mind of stuff that we maybe do every day sort of thing. I'm like, well, it doesn't seem that complex because we do it so often, but you should get credit for it. So where we're at. So the practical approach, the way to do this would be to work backwards. So you start with the medical decision making. So that's why I kind of said that I think the table of risk is probably the most important thing. You start with the medical decision making. You determine the level of the encounter that you should meet for based on the visit, and then you document appropriately. So like I said before, this isn't about, writing the best, most thorough note ever as a provider. This is, I'm focusing on what you need to do for billing purposes. So just keep that in mind. I'm not saying that, these would be the best notes anybody ever wrote, but they would meet criteria for the level of billing that, as it goes accordingly. So back to our case. So the kid that came into the ER, asthma exacerbation, got some steroids and some breathing treatments. How would we code this? So we pull up our risk table, and kind of like I showed as an example, this would be an severe exacerbation of a chronic condition. This is my opinion. She's getting breathing treatments, getting admitted, and got IV steroids. So, she's going to fit in right here for the high risk for the presenting problem. So how do we document the encounter? So we come back to our medical decision-making table, and we're at high risk, so we need to, here we need two of the three. So we need to make sure we either have enough problem points or enough data points for a high complexity encounter. So we have that. We have the data points. If you go back, they got labs, got a chest x-ray, got an EKG, so she was tachycardic. They got an EKG for those reasons. And say you admit her and you order PFTs the next day or a couple days later, sort of thing. So, I mean, that would give you at least 4 data points. So you would meet criteria there. So this would actually be, and we're going to get into this in just a second, but you would go back and document the history and the exam accordingly, and this would meet for a 99223 admission H&P. That requires a comprehensive history, comprehensive exam, and high medical decision making. And I'm going to get to those in just a little bit. Let's go to office visits first. So we'll do new and old office, new and established office visits, and kind of go through an example of each and go from there. So this is the table for new office visits, 99201 all the way down to 99205. And then this is the corresponding level of history, exam, and medical decision making for each. So problem focused, expanded problem focused, detailed comprehensive, same thing for exam. And then medical decision making, straightforward, low, moderate, and high. Now just keep in mind that there's time listed over here. This is in minutes, by the way, over here to the side, and I'm going to get to that kind of at the very end. We're just going to touch on that real quick. So an example of a new office visit, and I kind of alluded to this earlier, but so a 6-year-old white male, history of frequent otitis media, ADHD, diagnosed by Vanderbilt, age 5, recently moved to town, presents to your office to establish care with new PCP. Currently in the 1st grade, doing fair in school, 1A, 3Bs, 2Cs in his classes. Symptoms are better controlled when he stays home with mom, so mom and dad are split up, and he seems to do better when he's at home with mom. That's what we're talking about there. He takes low-dose Concerta. His mother acknowledges drastic improvements in his symptoms since starting his current medication. Denies any recent illnesses, no surgeries, no allergies. Weight and appetite are both stable. He's hanging around the 50th percentile on the curve. Denies any difficulty sleeping. Kind of a brief exam done. It's all pretty much stable. His vitals are stable. He's comfortable during the encounter. No acute distress. Chest is clear. Heart's normal. Normal PMI. Abdomen soft, non-tender. No hepatosplenomegaly. Pulses are intact throughout. So you decide to refill his Concerta, advise his family on healthy diet, good sleep habits, good sleep hygiene, schedule a follow-up visit in 3 months. So how do we code this visit? So if we think about kind of what we did, go back to the risk table and then come to the medical decision-making table. He has just a couple problems, otitis media and ADHD. As far as data, you didn't really get any data, so it's 1 or less for that. You didn't per se get any labs. He has moderate risk if we go back. So we refilled his prescription medication. So the medical decision making, the highest we would meet there would be low complexity as far as that was concerned, because you have to have 2 or more in the medical decision making table. So low complexity, we would need a detailed exam and a detailed history as far as this encounter. So 99203 probably for this visit. And like I said, just kind of keep in mind the time over here off to the side. So this kind of just goes over what we needed for the visit. So we need a detailed history. That's an extensive HPI. We need 4 elements for that. 1 of 3 past medical, family, and social, and 2 to 9 review of systems. We need a detailed exam which is 12 bullets based on the 97 guidelines. So if we come back, I'm just going to kind of highlight our extensive HPI elements just so you can kind of see how it fit, or based on the way I wrote it. So it was diagnosed, ADHD was diagnosed at age 5, so he's had it about a year or so. So that kind of gives you the duration. Modifying factors sort of thing would be, okay, well, it's better when he stays with mom as opposed to dad. This kind of gives you an idea of the severity of it. He's just on a little bit of low-dose Concerta, and he also illustrated what his grades are, so that kind of gives you an idea of the severity. And then drastic improvements in symptoms since starting his current medication, so kind of the complexity of it, and then, again, kind of modifying symptoms. So, on to established office visits. So, kind of similar, 99211 all the way down to 99215. And you can see, like, for the 99211, there's nothing required for that one, and it only takes, or it only takes 5 minutes. But as far as no documentation being required, this is basically like the equivalent of a nurse visit. No provider needs to be present for this level visit, and this is hardly ever done. So now one thing, I don't know if I mentioned yet, but I may hit on it later, but while I'm thinking about it, for the new office visits versus the established office visits, for the new ones or an admission H&P, so basically any new encounter, whether it's inpatient or outpatient, you need all three to meet for that level of billing. For an established office visit or for a follow-up like hospital progress note, you only need 2 out of the 3. So that was kind of a key difference, and it was kind of easy to remember because new versus old, inpatient or outpatient, it's easy to remember. I need 3 out of 3 for this visit or 2 out of 3 for this encounter. So example of an established office visit. 45-year-old white male smoker, history of diabetes, hypertension, high cholesterol. Here for a 6-month follow-up, has no acute complaints. His diabetes is stable, fairly well controlled, only on metformin. Last A1C was 7.1. That was last visit. Hypertension is not adequately controlled, as his home blood pressure log indicates that his average blood pressure is about 150/95. He's on lisinopril 10 milligrams. Cholesterol is stable on Crestor. He doesn't have any side effects from that medication. You do a brief review of systems. Physical exams benign. I didn't write it all out here because it would have gone off the page, but just per se say that I documented the criteria needed for the level of physical exam that we'll see we need. Obviously, you can't just write this in the note. So you refill his metformin, so medical decision-making or assessment and plan. Refill his metformin and his Crestor. You increase his dose of lisinopril. You order annual labs. You get an EKG because of his uncontrolled blood pressure to evaluate his heart. And you perform smoking cessation, schedule a follow-up visit to reassess his hypertension and titrate his meds. So this is back to our table of risk. So we dealt with prescription medications here, so we would at least be at the moderate level. So back to how do we code the visit. So he has multiple problems. You did get some data, and we'll come back to that. And we talked about the moderate level of risk based on the risk table. So we only need 2 out of the 3 for this, so we should be at a moderate complexity visit. If we come back to our table for established office visits, moderate complexity medical decision-making would put us at a 99214. And this is pretty standard for us in medicine clinic. Like I said, people come in with 3 problems. They needed an extensive HPI. We list their 3 problems and say kind of they're either stable or need to be addressed, that sort of thing. And we should fall in at a 99214 for that visit if we're coding properly. So we would need a detailed history and a detailed exam for that. Actually, we would only need 1 because we already have the medical decision making. So if we document that appropriately, like I said, we only need 2 out of 3 for an established visit. So detailed history, an extensive HPI, we would meet that because we listed his 3 problems. We need 1 out of the 3 as far as his past medical, family, or social history, and we just need to review 2 different systems. Detailed exam, which is 12 bullets from any 12 bullets, so they don't have to be from certain systems, and that's per the 97 guidelines. And then, like I mentioned, thought I would hit on this at some point, but I couldn't remember when. For established visits, we only need 2 out of the 3 elements from history, exam, and medical decision making. So we come back here, and that right there meets for our extensive HPI as far as that's concerned. Our social history, this is our review of systems. That's something else to mention. You know, it doesn't have to be an exhaustive review of systems of that system to say, so you don't have to say chest pain, orthopnea, palpitations for cardiac. If you just say no chest pain, I mean, that meets criteria. So back to just to kind of review new versus established visits. Patients consider, these are a few things just to kind of keep in mind. And these kind of all say the same thing just in a different way just to kind of make sure I hit on it. Patients considered a new patient if they're not previously seen by you or one of your partners in your practice within the last 3 years. So if you followed someone and they either moved out of town or they were just lost to follow-up for whatever insurance reasons or whatever, and then they come back and reestablish care with you and it's been more than 3 years since their last visit, then they can be coded and billed as a new patient now. Established patients can become new patients. If you think about what I said here, they're lost to follow-up for greater than 3 years. Patients considered an established patient if they were previously seen by you or your partners in the last 3 years. So the important part here is not so much the 3 years, I kind of hit on that already, but people who were seen by one of the partners in your practice, in your group, you can't see their patients one time, they're out of town that week on vacation sort of thing, and it be a new visit. I mean, they're known to your group, so that's considered an established patient. So just kind of keep...
You told me Medicaid in this state, it's a 1 year.
I didn't read about that, Doctor. I didn't read about anything specifically to Louisiana. I don't know.
I don't think that's true.
I haven't heard that, or I didn't see that anywhere. Yeah. Everything I saw was 3 years was the timeline. So inpatient encounters, and we kind of hit on this with our first example. So there's 3 levels of billing for inpatient, level 99221, 222, or 223. This is for admission H&Ps. And then these are the levels of the 3 elements needed for each of those. And then note again that time is written on the side, and I'll get into that. So for admission H&Ps, 3 out of 3 are needed. Hospital progress notes, so it's a 231, 232, and 233. These are the levels needed for each. And then again, times on the side. And you only need 2 out of 3 are required. So one thing that he did mention, obviously, so like for a detailed history, you need to mention 1 out of 3 of the past medical, family, and social to meet for that criteria. There's an exception here with hospital progress notes. Obviously, there's been no change from yesterday to today in that history, probably. So that would be an exception here. You don't have to, per se, mention that, hit on that one point, obviously, because it's the same. So just kind of keep that in mind. I don't think I had that written up here anywhere else, but that is something kind of that I came across. Most of the time, if we're doing a fairly decent exam, our exam is going to meet for criteria, and then obviously our medical decision making should meet for whatever level we're billing for. That obviously that needs to be one of the 2 that should meet. That's not a rule, but that's just kind of, I mean, that would be good. It'd be kind of, it wouldn't make sense to have the history and exam meet and then not have an assessment and plan at the bottom of the page. So, so really and truly, you probably only need, you only need 2 out of 3. So. So another quick example. So 3-year-old white male has a staph, soft tissue, or skin infection. Submitted a couple days ago. Has had a IND done by surgery, did wound cultures. It's sensitive to vancomycin, so you're treating the kid with IV vancomycin. He's on day 2 of IV vanc. Plan to get a vanc trough today, check his levels. It's been afebrile for about 30 hours now. Parents indicate he's got a good appetite. No diarrhea or vomiting. He's doing well playing out in the hallway. He does have some intermittent local pain at the site of the wound. He's getting Spirin and Tylenol for that. His vitals are stable, lungs are clear. Heart exam, abdominal exam, pulses, extremities, all of that's normal with the exception of the wound on the extremities that you note interval improvement of the surrounding erythema around the wound. So you review his labs, his electrolytes are normal, renal function's normal, plan to continue IV antibiotics, follow up his venk trough later today. You discuss with surgery the intraoperative findings. You plan to repeat an ultrasound, soft tissue ultrasound, just to make sure there's no reaccumulating fluid collection. And the kid's new to you, so you obtain his records from his PCP. You hadn't quite gotten them back yet. Check to see if he's had frequent skin infections, that sort of thing. So where do we fall here? So we start off, we're going to go backwards, start with our medical decision making, and then start with the risk first. So kind of like I talked about earlier, we've got IV drug therapy, IV vancomycin, and we have to monitor his levels so he doesn't get, say, an AKI from his venk trough getting too high. So he should be at high level, high complexity, high level for his level of risk. So for hospital progress notes, this is our table and these are our levels. Medical decision making, we should be high here because of his risk if we meet with either his problems or his diagnostic data as well. So we need 2 out of 3 for medical decision making. So we need a detailed history, a detailed exam, and high level medical decision making because this should be a 99233 encounter. Now, once again, we only need 2 out of the 3, but I just kind of, listed all 3. But it's a follow-up visit. It's a hospital progress note. So, like I said, 2 out of the 3 is required. So that's pretty much it on inpatient, outpatient stuff and kind of the basics. I'm going to kind of briefly hit on well-child visits and just kind of a few little things on here. I'm assuming that Epic, when we click Kid Med, and we don't ever type these in, I'm assuming this correlates with hitting either established or new Kid Med visit, that these code levels meet, because this is how they're broken up. If you do like the charge capture section in Epic yourself, the residents kind of know what I'm talking about. It's by age, and then it's either new or established. So these are the levels for that. So you would bill this for any well-child visit. And then, like I said, the kids that come in like with an ear infection or a runny nose or that sort of thing, well-child visits, you would use this code, and then we would put the 25 modifier on there, which there's a section for that, where you basically bill out for like a straight, you would do it as appropriate for if you went through your medical decision making and history and that sort of thing. Obviously, it all needs to be documented appropriately, but most of these come out to be a straightforward visit, so like around a 99212. I suppose you could have a 213, but usually they're like a 212 sort of thing. So, so we would bill that on top of the Kid Med visit. So just kind of briefly touch on coding based on time. This is typically done in the ICU setting. There's a few things. It can be done anywhere. You can do it in the clinic, in the office. There's a couple rules to keep in mind. So if you code based on time, you don't have to meet the documentation criteria as I kind of outlined it in the last 50 slides. The rules are, it requires the entire allotted time to be face-to-face with the patient, like in the clinic or at the bedside, like if it was in the hospital or in the ICU. More than half of the time in the clinic during the visit needs to be dedicated to counseling, and you have to document, you have to break it up. So, 30 minutes for this encounter, 17 minutes were dedicated to counseling on X, Y, and Z, whatever as it pertains to the visit. Generally, it's more efficient to code based on the documentation requirements and not based on time. So what's required for the history exam and medical decision making to meet for that level. So usually it's more efficient to do that, which is why everybody does that. These are my references. Most of it was, there's video lecture series done by Dr. Jensen. This is the website for it. He's an internist in Connecticut, I think he said. He's a certified professional coder as well. So most of this was kind of from that lecture series, and then there was some stuff from the AAP, and then obviously his lecture series is based on the documentation guidelines from 95 and 97. So obviously that, that's where he got all of that from and where some of the tables came from. And then a little bit of stuff from the AAP about the well-child visits and that sort of thing. That's it. Does anybody have any questions?
That was good. A couple of things for the residents when you're coding. Well, one, if a child is born here, they're established. So,
Yeah, I was going to mention that, the LSU rule, but I forgot to hit on that.
so if they're born here, they're established. So whenever they come for their first visit in the clinic, even though they've never seen the clinic, they're an established patient. The other thing, if you have an established patient, so generally it kind of works out as far as the number of things you have to document, that a new patient is coded one less. So if you normally, if you're seeing that patient and it'd be a 99213, a new patient would be a 99202. You get paid more as a 2 than a 3 established. So it, but because you have to have all 3 of the net, and I think on there, you put them side by side, there's more documentation for a higher code than in an established. You still get paid more even though it looks like it's coded lower. But that's one of the things to remember. So if you normally, if it's a well child essentially and they're just coming to be established and don't have a lot of problems, it's not a 99203.
If they just come in for an HPV shot or flu shot, do the residents go and ask the whole situation? Do they become like 212 or? They just come here with just like a shot.
Like an HPV thing?
Yeah, if you just do just a problem focused, minimal, it'd be a 2. If it's a nurse only, then it'd be a 1.
Like the contraception, those, a lot of times Ms. Tracy does those.
And then the biggest thing that I see on the floor, other than the review of systems being missing, and if the review of systems is not complete, we have to bill for the lowest level. It doesn't matter how pretty the rest of your H&P is. It doesn't matter that your assessment and plan is 3 paragraphs or 3 pages long. If there's not 10 review of systems, or it doesn't say all reviewed and the rest are negative, then it doesn't matter how much else you wrote in that note. We have to charge for the lowest level. And then on the daily notes, a lot of your plans are very long and very detailed, and they meet complex medical decision making. The history, or the S part of your daily note, says no complaints today. That doesn't meet anything at all. And then your physical has 3 points in it. That doesn't meet either. So even though you have this long plan, I don't have anything else. So again, basically it's a waste of everybody's time because we're not getting paid for what y'all are doing, which is the thinking part, which is the assessment and plan. It doesn't take a whole lot more to put a few more bullets in your physical exam.
One other thing on that point is, I didn't do it here, but like the lecture series, the video lecture series that Dr. Jensen does, like every example that he gives, he goes back and says how many words he used to document that note to meet that level and what that level was worth. So it was basically just to kind of illustrate coding efficiency, and I'm not, this isn't all about making money or anything, but he was just kind of making a point of like these big long assessment and plans that basically say what you could have said in like 5 little points. That's great and it's pretty, but you don't get, any other provider ought to be able to read the 5 points and know what you're talking about. You don't get paid for it. It's a waste of time, basically. and a waste of effort and, you know, typing all that out, so.
And if you don't have the physical to match it,
Well, then it's really a waste of time.
then
yeah,
it's
if you don't
really
meet
a waste of
criteria,
time.
yeah.
I mean, y'all work hard. Let's get paid for what y'all do.
Anyway.
So in case I'm receiving a new patient for obesity and hypertension, I have initiated the workup, and but at the same time, I'm spent about half an hour counseling on lifestyle modification. Is there any way I can get separately for counseling and also build level 4 for obesity and hypertension?
I don't know about that, Dr. Nadeem. I don't know the specific example, but I think there's a way we can bill for certain things, like like smoking cessation. There's an extra code for that, I think, like in our you know, medicine clinic. I don't know what it is or how to do it, but I think there are certain things that you can bill for counseling on that in addition to the actual visit itself. So I'm not for sure. Rules.